So, first of all, a big thanks to Ashu Alexander Achan, our deacons, and for the OASSIS platform. I'm sure visionaries have created it. And thanks to Ashwin for giving me this first opportunity to come and talk on this platform. I hope this really, gets a blessed platform and empowers our students the world over. And I see a big scope. I've been speaking to Ashwin about it. And there's a big scope for this. But what's interesting is he's given me the topic, holistic care. So I think I didn't choose the topic Ashwin has given me. So, and as you can see, my interest is in sepsis, deteriorating patient, clinical informatics, antimicrobial stewardship. So holistic care is nowhere near there, but my wife is a general practitioner and I had to learn holistic care from her. She was from her to do this presentation. She's Shiny Sam, that's her name. So I work as a consultant anesthesia intensivist, actually, both at George Eliot Hospital, Nuneaton in UK. And I'm so delighted to see all these youngsters, and I look forward to more sessions. Obviously, my area of expertise is what I really look forward to, which will be acute medicine and acute care rather than holistic care. But that's fine. I have a good topic to start with, a good, really foundational topic to start with. So let me see, I can scroll and see. Yeah. So I believe all our students are there right now. Is it okay if I make it slightly interactive? Otherwise, it could get a bit boring because it's not a big topic. And is it okay, guys? Girls, everyone?
Yes.
Yeah, good. Yeah. So that's the fun part of it, make education interactive. Otherwise, because then you get very focused and it goes into long-term memory. So that's how you push things into long-term memory, by being interactive. So what is your concept of holistic care? What is your understanding? One or two people can tell me, what do you mean by holistic care? What do you think is holistic care? It was such a difficult topic for me because I had to think through this quite a bit, search quite a bit, understand, refer, and speak to my wife to get the details. So what is your understanding of holistic care? Anyone?
Care. I think, go ahead, Ashley.
Yeah. It's care overall, right? So not just medically or spiritually, just everything, mentally, spiritually, emotionally, every aspect of our health, rather than just focusing on the medicine part of it.
Absolutely. I think that's the interesting bit, We often see patients as patients and with sickness. That's how we see them. I think holistic approach is what we actually meant to practice, and we don't reach there. So I'll just take you through what the definition says. First of all, before we say holistic, we should know what is health. What is the definition of health? It's a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. See, that's so interesting. It's a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. As per WHO, I think the definition remains unchanged since 1948. Is that interesting? To put it in perspective. I think it's time. Yes. Yeah, very good. I think, yes, absolutely. As medical students, this is the time to get introduced to these terms, be thorough with these terms so you know what you're going to deliver in your life. And as Ashley said, it's actually an attempt to treat the whole person, including mind and body, not just the injury or disease. And that's the first place I looked up. That was Cambridge Dictionary, to understand what is, how is it defined, okay? So I'll straight go to what is called the biopsychosocial or holistic approach. This is the approach we are meant to follow. So you're a biological being, your psychological needs, and then you have social, all well-beings around you. So illness have both mental and physical components, and there's a dynamic relationship between them. A holistic approach can be defined as an approach that integrates all these components: sociological, psychological, biological. Could you kindly give me an example of sociological? What do you mean by sociological?
Housing conditions, occupation.
Absolutely. Housing conditions, politics, policies, government policies. That all falls under sociological. You see that? And we know psychological and we know biological. Often we don't think about sociological. So from today, I'm sure you are empowered to think about the sociological changes which are evolving in the healthcare arena. You see that? How it's going to evolve. Keep a watch on it. So you'll become more conscious about it. Put these components together and you have the basic holistic approach that treats the patient as a whole. Okay? And this approach has been strongly advocated by the Royal College of General Practitioners. I was a bit surprised at that. I never knew the Royal College of General Practitioners was really into the biopsychosocial approach, or the holistic approach. And it's strongly advocated by them. When I came to this country first and went to a GP, the question that he asked me first was, so what can I do for you? I was a bit surprised at that. Because coming from Kerala, where you're asked, Endanasum, they may ask like that, Endanasum, and this is totally something different, What can I do for you? And what do you think brings you here? Very, very strange questions. I didn't understand, Actually, he was trying to get into that, what they practice called ideas, concerns, and expectations. That's what they try to elicit. What are the ideas that you come with? What are your main concerns? What are your expectations? And it has huge implication in getting into understanding this sociological, psychological, and biological problem. So those are the opening questions, and that is a structure that they use to navigate and make the patient commit on all these areas, which I didn't realize at that time. I found it very funny, actually, when he asked me that I thought, so he's supposed to tell me what my disease is, and he's, acting strangely. So suddenly there's a shift in things. And probably we were practicing a bit of my biomedical rather than biopsychosocial. So how has this evolved? How has this philosophy evolved? So let's have a look. So this was, there's a 17th century philosopher, René Descartes. He identified a distinction between the mind as a non-physical entity and the body as a physical entity. See, there was a disconnect that he had in his theory or in his approach. And obviously it was, quite early on, 17th century. And this has carried on in quite a few parts of the world. The mind as a non-physical entity and the body as a physical entity. Still, there are deeper arguments on, is a mind really physical, or is it a consciousness and things like that, okay? But what's interesting is there was a disconnect between the mind and the body here. And so this was the biomedical approach which was used in the past. Now the biopsychosocial, as you can see, has all these, I've got the Venn diagram here, which shows you the biology, social aspects, psychological aspects. Can you see that? Physical health, biology, physical health, genetic vulnerabilities, drug effects, social from your peers, family circumstances, social circumstances, family relationship, psychology, coping skills, social skills, family relationship, self-esteem, mental health, all that falls here. This model was developed by George L. Engel in 1977. And he emphasized that the biomedical approach is flawed because the body alone does not contribute to illness. The body alone does not contribute to illness. I think it was so well thought, and that has become the model for the present. The social aspect has actually greatly expanded through ideas such as spirituality and culture. You see that? It is a social aspect which has become, extension of the social aspect is the ideas such as spirituality and culture. It'll be very interesting to see that a lot of the modern biopsychosocial approaches of different countries, they may not mention the spiritual aspect. And that's very interesting. But that's what it is, So it's an extension of all the social aspect, spirituality, culture, and things like that. And this is where the mind, body, and the spirit or the soul, there are different kinds of psychosocial approaches. Different systems are made. It could be the mind, body, spirit, mind, body, soul, mind, body, heart, brain. So there are many of these types of philosophies which are joined together. But this usually forms the cornerstone for that, the foundation for it. So what is our role? So you're all going to be doctors soon, junior doctors, I guess. And what is our role? Anybody can tell me? Go ahead, guys, give it a try. Yeah. Girls as well. So when I say guys, I mean everyone. What do you think is our role?
I think as med students, it's easy to forget that the people that we're treating are people. We get kind of wrapped up in the illness. So I guess our role is to always remember that they are a person and they do have psychological and social things going on. So we have to remember these things when we're treating them and treat them as a whole.
Perfect.
Yeah.
That's absolutely right. I think you still imagined yourself as a junior doctor, as a medical student, isn't it? That's what you started off. But I think imagine you are a real practicing doctor. And I'm sure if you think like that as a medical student, you're likely to do the same. And you're absolutely on the right track if you think like this. Anyone else? I think very important to have different perspectives. I'll tell you one thing before I proceed. I keep asking myself, how did I learn what I learned in my life? And it's very interesting. Whatever I learned is from others. See that? When I was born, I didn't learn anything. I didn't, learn and come. But you learn from others. And we often forget that. So as medical students, my recommendation is always try to learn from each other. When you reflect off each other, the assimilation is so fast of knowledge and the consolidation of knowledge is so good, you'll be able to recover it years later. Okay? So please do that, and therefore just participate. The whole idea about participation is, again, I'm very particular that whatever you learn, the yield of what you learn stays with you if only you can recollect, process and recollect. You see that? So it goes into your subconscious level. So if you can process and recollect, it's really worth it. So the more you interact, you're likely to remember more. Go ahead. Anyone else?
I'd say more to do with as a junior doctor. I don't know, like if we would be making a lot of decisions, we'd be doing more of the paperwork and stuff like that. But even then, when some patients are a bit like they want to speak to you or they want to know more about their illness, I'd say even though you're rushing through things, take like 2 minutes out of your time or 5 minutes out of your time and just speak to them, just see what they're feeling and things like that.
Absolutely. Yeah, absolutely right. I think you are absolutely right. Just speaking, that personal connection is what makes a difference. Personal connection makes all the difference. And, I've realized it throughout my career that people miss things because they don't talk to the patient. They make wrong diagnosis. One, always talk to the nurse who's looking after the patient and always talk to the patient. This is so key. And just, say at least when you meet them, greet them, all that makes a difference. I remember being in a hospital and, you just felt like statistics there. You're just a number. People come and treat you like you're not alive there. You're just a number with a disease. You see that? So very important that we interact with them. It makes all the difference in life to the patient. Okay. So the definition of holism widely accepted for medical care involves the caring of the whole person in the context of the person's values, their family beliefs, the family system, and the culture in the larger community, and considering a range of therapies based on the evidence of the benefits and cost. Look at how many factors have gone into there. Can you see? What are the contexts there? Person's values, their family beliefs, their family systems, their culture, in their community. And then you consider a range of therapies, not just one, a range of therapies. Based on what? Evidence. And then what? Benefits. See, benefit versus harm. That's how you pick up, that's what you look in evidence. What's the benefit versus harm? And then the cost. So that's so comprehensive. That's actually a curriculum course statement, being a general practitioner. So it's from the curriculum course statement. Okay. Now, holism or holistic approach and patient-centeredness. Often when I give a reference to people, I would say, always say, oh, such a patient-centered doctor, or this doctor is very patient-centered. And what's important is, I work in acute medicine. So do I practice holistic medicine? Actually, we have our moments too, okay? We also have our moments. Could any of you think of it and tell me what are the possible moments that an acute medicine doctor could be practicing holistic medicine?
Accident, trauma.
Accident, trauma, very possible, yes, yeah. And what do you think I'll be doing there as a holistic approach?
First thing is comforting the patient, so that assuring them that we'll provide them good care, and we'll find a way to to help them overcome this, whatever it is. And and also guiding them through the procedures, to steps in the procedures, whatever we want to do with that.
Okay, very good. I think that's definitely a few tick boxes there. So what I do is, when I go and see a patient, in A&E, I usually talk to the patient if I can. If they're very sick, I may not be able to speak to them. But assurance, exactly as you said, I try to be empathetic towards them, assure them. Then I move on to find out a bit more about the patient. And I go to the family. And it's so important to understand that this patient's, what was he like? That's so important. So I go and ask them all about him. Oh, I want to know the patient thoroughly. But acute medicine, we are more interested in cardiorespiratory reserves of the patient. See that? We want to know the cardiorespiratory reserves, cardiorespiratory and renal reserves of the patient. So I'm going into the physical more. You see that? As an acute physician, but at the same time, I'll try to understand, what does he do at home? What is his quality of life? What is that he can exert himself? What does he enjoy most? And, and then furthermore, then other habits, social habits, smoking, drinking, those kind of things are also elicited. So that's quite a bit we go into, If he's got any other health issues, we'll pick it up. What name does he like to be called? That's all, very specific. We may ask those kind of things. So again, biopsychosocial, we cover quite a bit, but not so much social but I may have to cover social when I discharge these patients. Imagine these patients are going. There are cases when we have to discharge patients directly into the community. Then we have to make arrangements for them, for their recovery, for their stabilization, physiotherapy, those kind of things. And their occupation, adjusting their, now I've got a patient in my ITU who's going home after around, she's just completed 90 days. She's not gone home yet after COVID. 90 days, 3 months stay in ITU. And so we were encouraged to do a full performer for telling these for their step down to the community. Got it? So that's what we meant to do. So we made a full plan for their community step down so that it's all arranged. And the nurses in the community have gone to see how their houses are, so that they can walk around and all those aspects, okay? So we have our moments too. Then comes good communication skills, okay? You got to have good listening. You have to listen to people when they talk. Don't break them. We're always in a hurry, when we are practicing. And they are very essential qualities for a doctor using holistic approach. Otherwise, you'll miss it. If somebody keeps coming to you, suppose you're a GP and people keep coming to you, and a person keeps coming to you, maybe they're coming out of their anxiety. Maybe they've got a history of cancer in the family. So there's a fear. If you fail to elicit it, this patient will never get corrected. It will not be rectified. So speaking is very important, and listening. And actually, our GPs are practicing holistic care, but not necessarily labeling it, their practice as holistic. So getting to the story behind the story, before that, just hold you all there. What is the time duration? I just wanted to check how much time do we have to speak? I should not be overrunning. Hello? Okay.
Yeah, we have literally like 5 minutes, doctor, if you don't mind.
I've got 5 more minutes, eh? Okay, thank you. So why has the patient decided to consult? That's very important. Asking these kind of questions. What does the patient think is the problem? What does the patient fear may be the problem? What is the patient hoping to get from this consultation? These are the basic questions you ask. So if you ask these questions, you'll be able to get behind the story, okay? Empathy is very important. Recognize the patient's perspective. Acknowledge the patient's thoughts and feelings, because it can affect their level of suffering and the speed of recovery that they can make. Pointing to resources. It's not allopathic medicine is not the only resource available and trusted by the patients. So if they're happy, you can always refer them to what they like, So an open approach. So psychological approach, social and government policy interventions, and complementary medicine are some of the aspects of holistic approach. A good history and examination. The experts say rushing into the examination without careful history taking is misleading. These are some of, have you seen MacLeod's clinical examination book? So that's where he says this, actually, rushing into examination without careful history taking is misleading. And it's common to focus too quickly on the detail and neglect to make general observations. So you're in a hurry and you're focusing too quickly on the details, but you're neglected the general observations. So passively surveying the patient's entire human condition and then zooming into the details of their pathology. So always you have a passive survey. I usually sometimes stand back and watch my patients, how they're behaving, how's their breathing, every aspect. So I get an overview of the patient. Then I go back and zoom into the details. So how do I approach the critically ill? See, you may have some curiosity, Those guys talking about, holistic, and what do you really practice? How do you practice yourself? So my approach any deteriorating patient when I approach is, all I can give in a hospital are these kinds of care, only 4 kinds of care: resuscitative care, supportive care, definitive care, or palliative care. So I wanted to bring the topic towards palliative care. That's why I've said that, okay? Resuscitative care, airway, breathing, circulation, you resuscitate, cardiac compressions, and things like that. Supportive care, ITU provides supportive care. And the whole principle is, what is the principle in ITU? Let the body heal while we support it with artificial machines. The body has to heal, okay? Then comes definitive care. So suppose they need a surgery, that becomes definitive care. They need an antibiotic, that becomes a definitive care. Remember this, because these are the four things you can always practice. If nothing works, the patient could be for palliative care or end-of-life care. So that's what we practice in acute medicine.
So one question.
Yeah.
So doesn't palliative care come under supportive care?
No, I think it's also labeled as supportive. Some people label it as supportive care. Okay. So this is, I just went through this. So palliative care, some people write it as supportive care. It can be called, anything can be called anything, but if it's a terminology that you use to approach things. So it's a system approach. You see that? So supportive care actually is organ support. That's my reference to. So we can all, what is written in the book is different from what you can create. You see that? You can be the creator or author of something. And so supportive care is about organ support, like respiratory support, kidney support, as we do in ITUs and things like that, okay?
Okay.
So palliative care is actually, it's a form of holistic care. That's why I had to build it up, of individuals across all ages with serious health-related suffering due to severe illness, especially of those near the end of life. And it aims to improve what? The quality of life of patients, their family, and their caregivers. And this is the principle behind it. So it's not just about the quality of life of patients, but their families and also their caregivers, okay? So as you can see, in the UK, we use palliative care and end-of-life care terminology, but I think it's Australian one, which is terminal care as well, Canadian one. So you start palliative care in somebody who's got life-limiting illness with usually poor prognosis. And the focus is on symptom management, just symptoms are being managed. And you focus on the quality of life improvement. And you try to give them psychosocial support, you know. End of life care is where, you know, the patient is not likely to survive a few weeks or months to live. And that's where you start end of life care. And again, the illness is where you realize there is no reversibility for the disease. It's non-curative, okay? And terminal care is where hours or days to live. And that's where usually you end up starting DNS CPR, do not attempt resuscitation. There's no point. What we tell the families, the larger question we ask is, are we prolonging life or prolonging death? That is how we approach it. They understand that very fast. So, okay. Next one. That's it. So my conclusions, so always ask this question, are we patient-centric or are we disease-centric? That's what you should always ask, okay? There's a lot of pill popping that happens in different parts of the world, okay? There are misconceptions, not alternative or it's not alternative or complementary medicine. Holistic, you know, care is not about just alternative or complementary medicine, but may include the use of complementary and alternative medicine. It does not dismiss conventional medicine. This is very important to understand. So it could be conventional medicine with others. Nutrition, exercise, homeopathy, prayer, acupuncture, meditation, or just a few other treatments that may be used together with conventional medicine as part of a holistic approach. So all this could be used, okay? The larger question people ask is, what is alternative, what is complementary, what is integrative? Alternative medicine is treatment used instead of the conventional, alternative, instead. Complementary, used alongside conventional medicine. Integrative, used within conventional medicine. I can give you examples of very interesting one, which is very dear to me. That's the new ozone therapy. There is something called ozone therapy. It's very interesting. It used to be alternative. It is building its way into integrative medicine. Okay, that's ozone therapy has been used for COVID as well. There's a lot of research happening at the moment. So take home message: holistic care needs the ability to understand the patient as a biopsychosocial whole. So that's how you think. It has to be patient-centric rather than disease-centric. Recognizing the whole person in the prevention and treatment of disease may hold the key to make some diagnosis for the doctors. So you have to recognize the whole person. But please stick to evidence-based medicine, okay? And regulations of your chosen field. So do not wander away, because if you practice, suppose you come back practice here in the UK, just stick to evidence-based medicine and regulations of your chosen field.